Purva, shall I start?
Yes, sir, we can start.
Okay, thank you, Purva. Thank you. Good evening to all. Can you see my slides?
Yes, sir. You can make it full screen.
Okay, thank you, thank you. Today I got two long cases and one case with for a good discussion. Let me start with the first case. This case is given by Dr. Joy. This is a story of a young lady. She has presented with 3 days history of positional vertigo with vomiting. Hallpike's test and test for horizontal canal shows the same type of nystagmus, which is maximum on horizontal canal testing. So this is the short, that's only short case. The case is short, but discussion is long. So this is the abnormality noticed on the patient is now lying on the right side. Lady is this is nystagmus you observed. It becomes less and less and subsides. Then his patient is placed on the supine nystagmus. Disappeared. Now lying on the left side.
Okay, right.
And this nystagmus observed on lying on the left side. Again decreased and stops after some time. It stopped. So you want to see the video once again?
Yes.
This is on lying on the right side. Look at the type of nystagmus. Then fatigues and subsides. Disappears. Left side.
Okay, right. Return.
Okay, subsides. So what do you think is likely diagnosis we should have in mind? It's a tough case.
Sir, on looking to right, there is a torsional nystagmus beating to right ears.
Correct.
And
correct.
on left it is torsional nystagmus beating to left, sir.
Correct. Exactly. What is absolutely correct. What you have said is a torsional nystagmus 1, no vertical component, and on lying on the right side, the first component is beating to the right side, geotropic, to the side of where the head is low. On lying to the left side, the first component is to the left side. There is no vertical, pure rotary.
Bilateral posterior canal, sir. PPPV, sir.
Bilateral posterior canal on both sides. In that case, the vertical the compound should be there, no? Now, when you get a pure rotary nystagmus position change, the first thing you have to keep pure one, you have to think is a central type of positional vertigo. Central type. If you get a pure rotary nystagmus, that's very unusual for a peripheral type of involvement. But it can sometimes occur very rarely. That's why this case has been brought. This patient totally improved after 3 days. There is a clue. It's not a central type, it's a peripheral type. So what type? That's the question. Okay, I think it's difficult now. So I think I'll let us analyze the problem one by one. That will make you understand. So I've prepared a beautiful slides to make you understand how this, in what happens in BPPV. That will make you understand the ultimate pathophysiology of this condition. The patient has purely rotary nystagmus, correct? So that means the rotary nystagmus is anti-clockwise fast compound on turning the right side, as you said, and clockwise fast compound on turning the left side. The side of, in which side is there, that side is the fast component. That means it's a geotropic type of nystagmus. Means change the direction of light to either side, the fast component is towards the ground. Now, how is it possible? Let us analyze the problem. Now, one presence of a rotary component in any nystagmus suggests that affection of one of the vertical canal is there, or output from the vertical canal is there. It cannot be due to a horizontal canal involvement. So it is not a problem of horizontal canal. Even though it is occurring on the side laying position, that position for your characteristic testing for your horizontal canal BPPV. I mean the tilting position, supine tilting position. This is not a horizontal canal BPPV. Supine roll test. Now, listen with a common posterior canal BPPV. Next question, because of the rotary component. No, because posterior canal BPPV produces vertical and torsional type. And the vertical component is upward. Here, there is no vertical component. Same is also applicable for anterior canal. It's anterior canal again, you should get canal rotary nystagmus, but there is a vertical component which is downward. So it's neither anterior canal, no posterior canal, nor horizontal canal. Pure posterior canal, pure horizontal canal. So what could be the problem? Still, it is a BPPV.
Mixed.
Pardon? Yes.
Mixed ones.
Yeah, mixed means what? Mixed, what all canal should be mixed?
It is geotropic, so it is usually in the horizontal canal that is not in.
Okay, I think I'll explain the thing little detail, then you'll understand this thing. Now let us first know the pathophysiology BPPV for the vertical canal. This is for the juniors. For that, first you should know the connections of semicircular canal. Because it is better to recollect our old neurology teaching and neurology learning of these canals, so that to better understand the pathophysiology of BPPV. Then a little bit about the vestibular physiology. The utricle and saccule are responsible for sensing linear acceleration, gravitational forces, and tilting of the head. And semicircular canals provide information regarding the angular acceleration that you all know. And vertigo results from dysfunction of the semicircular canal. So statement number one is a disorder of semicircular canal. So we must know something about the semicircular canal. So let us go to the canal now. There are three canals, as you all know. One is the lateral horizontal canal. The plane is oriented horizontally. Then anterior, or otherwise called superior canal with the upward convexity, as you can see there. Posterior canal with the posterior backward convexity. Backward. I will show the subsequent pictures. This will be elaborated later in detail. So these are the three orientations of the canals. Horizontal canals are both labyrinths on the same plane. Both are the same plane. Unlike the anterior canal on the both sides or the posterior canal on both sides. In anterior canal on one side is the same plane as the posterior canal on the opposite side. That is the point to remember that. So the yoke canal for the horizontal is on both sides are there. But for the right anterior canal, it is a left posterior canal. For the left anterior canal, it is the right posterior canal. That is a yoke pair. So for example, that is the orientation of the right anterior canal. And that is the orientation of the left posterior canal. So when the head moves in one plane, these are the canals which are facilitated or excited or inhibited. Each of the semicircular canal is stimulated by movements in its plane. For example, if it's a horizontal canal, the horizontal movement stimulates or inhibits that canal. The corresponding semicircular canal of each ear are yoked in such a way that when head rotates in one plane, one canal in that plane increases its firing rate, and the corresponding paired canal on the opposite slows its firing rate. For example, my both canals are paired, right horizontal canal and left is paired. When the right is stimulated by turning the head to the right side, the left canal gets inhibited, and vice versa. That is how the canal is oriented. So similarly, when one anterior canal is stimulated, the corresponding pair, that is the left posterior canal, is inhibited. That is how the arrangement is set, so that one canal, the corresponding pair is inhibited. Each of the three semicircular canals, when stimulated by movement in its plane, induce eye movements in its plane. That is Florentz's law. Suppose a horizontal canal is stimulated, the eye movement induced by the movement is horizontal. The vertical canal is stimulated, it is vertical as well as torsional because, as you know, the vertical canal is mediating both torsional movement as well as vertical movement. The canal planes are also roughly the pulling plane of the eye muscles. The pair of horizontal canals lies in the pulling plane of the lateral medial rectum, that is, the eye moves horizontally. On the other hand, look at the pulling plane of the vertical canals and vertical muscles. Look at the plane of superior rectus, that is the superior rectus plane. Same is the plane of inferior rectus also. So that is a plane of superior and inferior rectus, corresponding to the plane of the anterior canal that will come later on. What is the plane of the superior and inferior oblique? In this direction. Okay. And let us put this position of the direction of action of muscles into the plane of our canals now. See, the posterior part of the picture shows the canal position. The anterior part is the arrangement of the muscles. See, this is the posterior canal, which is, this anterior canal on the same side on the right side. And that is corresponds with the direction of action of the superior and inferior rectus. Okay, that's why anterior canal movement will produce that movement in that position plane. So anterior canal is oriented in the plane of superior inferior rectus. That is the direction of the posterior canal, and that is oriented in the plane of the oblique muscles. Oblique is coming from anterior to posteriorly, from medial to lateral like this. So that is the same plane in that oriented. So when one posterior canal is stimulated, that the pain is in terms of an oblique muscle contraction. When the anterior canal is stimulated, that movement is the direction of a superior inferior rectus contraction. What is the function of superior semicircular canal? Is it detects angular acceleration and deceleration, senses motion, but not motion the constant velocity. Because when the fluid is moving constant in a uniform pattern, uniform velocity, it will not sense. Only it moves faster or decelerate, the ampulla will be stimulated. That I will be talking a little later. This is because of the fluid mechanics. So for suppose you got a pot or what do you call a tray full of water and put a paper boat on the top. You pull the tray forward, the boat will go backward. Each of the semicircular ducts contains a dilatation near the opening of the utricle called the ampulla. The ampulla contains a sensory receptor called the crista ampullaris. That is what is shown here. Ultimately, the stimulation of the canal is the deflection of the cupola, which stimulates the hair cells, which is embedded in the cupola. When the cupola moves, the movement of the hair cells occur, which is the stimulus for semicircular canal. The hair cells are two types, kinocilium and stereocilium, that you need not bother about much about it, because it only tells you when the hair cells are moving towards the kinocilium, that receptor is stimulated. So that is, when the hair cells shift towards the kinocilium is the largest, longest, tallest below, that canal gets stimulated. When the hair cells shift away from the kinocilium, that canal gets inhibited. That's the basic principle. Now, the arrangement of hair cells in the cupola is different in the horizontal and vertical canal. Say, in the horizontal canal, the orientation of the kinocilium is such a way that when the endoleaf moves towards the ampulla, the horizontal canal gets stimulated. See, that is the direction. If it's horizontal canal, when the flow is towards the ampulla or the crista, that canal is stimulated. That is because that is how the craniosacrum is oriented. On the other hand, in the case of vertical canals, when the flow is away from the ampulla, that canal gets stimulated. So these are two things. When horizontal canal, when the flow is towards that, it is stimulated. In the case of vertical, it is away that will stimulate. Now put in simple terms, there is horizontal canal. When the flow is towards that gets stimulated. In the case of superior and posterior canal, the stimulation is away, the movement of the fluid away from the ampulla. Now this is Evart's law. That is, generated nystagmus is always directed parallel to the plane of the stimulated canal. Second, generated nystagmus is stronger when the endolymph moves towards the ampulla in the case of horizontal canal. Generated nystagmus is stronger when the endolymph moves away from the ampulla in the case of vertical semicircular canal. This we told before. Now let us see what happens when you move the head normally as well as in pathological state like BPPB. The endolymph movement is opposite the direction of head rotation. As told before, when tray full of water is there in the paper board, when we move the tray forward, the fluid goes backward because of the inertia. Okay, the tray is moved forward, the fluid will be going backward. So when he begins to rotate, the membranous and bony labyrinths move along with that. However, the endolymph, the fluid within that, because of the inertia, lags behind the surrounding membranous labyrinth, thus rotating within the canal in the direction opposite to the head. The fluid is inside the canal, that is moving in the opposite direction. So, for example, here you can see that you are viewing the head from behind. The patient is lying there. You are standing behind the patient's head, and you can see the orientation of the semicircular canals. And here, the head is moving towards the left side. Okay. Then what happened? The fluid motion will be the opposite side, in the opposite direction. So the flow in the horizontal canal is opposite to that is called the clockwise, while the other is anti-clockwise. See the canal, what happens? The clockwise movement is this way on the right side and that way on the left side. Okay, now I am enlarging the horizontal canal for the easy understanding. See, this is the left side on the left side. See the direction of the flow. On the left side, it is towards the ampulla. So that canal gets stimulated when you move the head to the left side. What happened to the flow on the right side? It is moving away from the ampulla because the fluid moves opposite the head movement. So that canal get inhibited. So that this is occurring, see exactly same thing occurring in the paired anterior and posterior canals. When fluid is motion is on one direction stimulating that cupula, the fluid in the corresponding yoke pair is inhibiting that cupula. That is how it has been oriented. Now let us little bit again the orientation of the various canals. See, this is the orientation of 3 canals. So horizontal canal senses rotation of the head as it turns right and right. Like this, that is a stimulation of the horizontal canal called the no-no movement or yoke plane movement. The anterior canal senses rotation of the head front backward like that. Yes movement. That is the position where the anterior canal stimulation. See the orientation of the canal, it is forward like that. So it has to be in this direction. On the side, posterior canal is towards in the rotational plane, that is in the roll plane. The posterior canal senses tilt towards the right and the left ear, like this with the roll plane. I'll show this picture. This is how the patient is straight looking in labyrinth, right labyrinth viewing from front. This is how the various canals are oriented: horizontal, superior, as well as the posterior canal. When the patient is moving the head to the right side, okay, from the right side, the yoke plane, what will happen? The fluid will come forward because the head is not backward. So the fluid come forward towards the ampulla. So when the head is turned to the right side, the right horizontal canal, the fluid is towards the ampulla. That means that canal gets stimulated. That is the stimulation of the horizontal canal. When the head turned that side, that canal horizontal is stimulated. Now let us see the pitch plane going forward like that. That is the plane in which the anterior canal is stimulated. So what will happen? When the head is moving forward, the fluid will go backward. So the fluid in the antecanal goes backward. So as told before, in the superior anterior posterior canal, the stimulation is fluid going away from them. So here what will happen? The superior cervical can get stimulated when the patient is taking forward, and the flow is away from that cannot get stimulated. And only if the antecanal moves backward, there is ambular fugal. Fugal means away from the ambule, and stimulation the antesemicecond canal. Now coming to the roll plane like this, turning towards the one side. So look at the posterior canal here. The fluid will be again moving away from them. Turning the right side means it is going, fluid is towards the left side. So again, fluid is moving away from the ampulla and that cannot get stimulated. So these are the three planes in which the various canals get stimulated. Now we sense direction of motion depending upon which canal is stimulated. When you move the head, the semicircle gets stimulated. Suppose when you move the head like that, the canal gets stimulated. But why don't you get vertigo then? If it is BPP is producing by stimulation of the semicircle canal, that produces vertigo. When you move the head, why does it produce vertigo? This will not occur because vertigo results from a mismatch between the two labyrinthine input. As told before, when I turn head to the right side, the right horizontal canal is stimulated, left is inhibited. If the right is stimulated without inhibition on the left side, then vertigo occurs. It is a mismatch between the counterparts which produces the vertigo. The input is matched, we sense motion and no vertigo. And what is this matching? As shown before, when you rotate your head to one side, the position of cupola is in such a way that the fluid motion is towards the cupola in one canal and away from the cupola in the corresponding pair. For example, if one antecanal is stimulated on one side, the opposite posterior canal gets inhibited. That is a thing normally should occur. Only when is stimulated without the inhibition of the other, you get vertigo. So during normal motion, when one canal on one side is stimulated, brain expects corresponding and equal inhibition of the corresponding pair. That is how the brain has been calibrated. When one side alone is stimulated or inhibited, the brain does not accept the mismatch and then hallucination of movements occurs, vertigo will occur. That is when BPP we get vertigo and only one side is stimulated. The other side is not affected because dislodge autopony is only 1 year. And that is what happens in BPP. Now, this already told before, the vertigo occurs, there is a symmetrical mismatch between them. Now, basically, this you all know, just for completion's sake, two pathophysiological mechanisms response to BPPV. The basic problem is what? The detachment of the autoconia from the utricular macula, which falls into one of the semicircular canal. Because the autoconia should be only in the macula and saccule, not should be in the canals. But here from the dislodge get into the canal. That is why the problem starts. And once in the canal, there are two things can happen. The dislodged autoconia can lie freely floating on the canal fluid, or sometimes get attached to the cupola. Remain free in the canal or get attached. When it's free in the canal, it's called canal lithiasis. So that when the head moves, the particle move within the fluid. Under the cupola lithiasis means the particle get attached to the cupola. So the particle does not move in the fluid. The cupola here becomes weighted, because additional weight because of the particle. So the cupola will direct shift in terms of the weight. Suppose the weight is there, towards the direction when you tilt the head, it will tilt. In canal lithiasis, the degenerate autoconial debris detaches from the utricular matrix and inappropriately enters one of the three semicircular canals, namely posterior, horizontal, or anterior. Most commonly, the debris enters the posterior canal, followed by horizontal canal, leastly the anterior semicircular canal. In cupolar lithiasis, as told before, the autoconal debris becomes attached to the cupola, making it heavy and gravity sensitive. Now, this is the orientation when the patient is looking different. This orientation of the various canals. So you can see the posterior canal is behind, going like that. Horizontal is like this. This is the utricle which you see there. The utricular otoconia, when it leaves from the utricle, it is easy for that to enter into the posterior canal because that is just behind that. Gravity, it comes down to into the posterior canal, and that happens to the commonest type, 80% to 90%. Sometimes you may get into the horizontal canal, that is a less common type, 10%, and least into the anterior canal. Unless some maneuvers are tilting the particle has got misdirected into the anterior canal, normally it is not present directly. It's very uncommon to have a pure anterior canal BPPV. It's only less than 1%. Now, deflection of the cupola is determined by the direction of flow of pendulum in canal lithiasis and the position of the ampulla in relation to gravity in case of cupola. It only means in which direction the cupola is tilted. That either stimulated or inhibited. Towards ampulla, it is stimulating horizontal canal, away from it, posterior canal. Whether it's a fluid motion or whether because of the weight, excess weight which is attained because of the deposit of the particle on the cupola. Deflection of cupola may be different in canal lithiasis and cupolar lithiasis. In canal lithiasis, when the head moves, the dislocated otoconia moves inside the canal, resulting in fluid motion. The reflection is in the direction of the fluid motion, which is opposite to the movement that which already told. In cupolar lithiasis, cupula shifts the direction of gravity because it becomes weighted. Now let us see our common garden variety of posterior BPPV and how does it produce the vertical and dorsal nystagmus. Now why I'm telling is that this is, if you know the mechanism, you can explain the various types of this kind of aberrant BPPVs or uncommon BPPVs. So this is how, look at the picture above. You are, the person is lying on the bed, you are looking the skull from behind. And that is a position of the right posterior canal, right? That is now getting dislodged, the particle is getting stimulated. So this is the position of the canal. Now suppose when you turn the head right side or 45 degrees to the right, what will happen? The posterior canal now become vertical. That is the orientation of the canal because delta to 45 degrees. Now you move the head backward, straight backward like that, as you do in Hallpike's maneuver. The ampulla becomes uppermost and the otoconia moves away from the ampulla. See here, look at the ampulla here on the left side. Now if you move backward, what will happen? The ampulla becomes anterior and upward. From below, it becomes more upward. So what will happen? The particle will gravitate away from the ampulla because ampulla is upward, the particle will come downward. So the ampulla it's what will happen? Fluid away from the ampulla stimulates that posterior canal. The posterior canal gets stimulated. So for example, I'll show the picture. If you view from behind, when you rotate behind, the particle moves away from the ampulla like this. So that canal gets stimulated. That is the right posterior canal BPPV. This is putting simple terms and another same another picture. This is a free flowing particle lying there. This is head upright. When you tilt the head like this, the particle move away from the ampulla and that will get stimulated. Now let us see how this is produced in nystagmus here in posterior BPPV. This is very important to know the connections of the anterior and posterior semicircular canal to understand not only this BPPV but also your vertical upbeat nystagmus, downbeat nystagmus, rotary nystagmus. All this pathway connection is very, very important. It is simple to remember one dictum. Anterior canal is connected to the upward or superior canal is connected to the superior moving ocular muscles of the opposite side. The posterior canal or the inferior canal is stimulated to the inferior moving ocular muscles opposite. You remember that thing. Superior, superior, inferior or posterior, inferior. Remember that thing. Now let us see the posterior canal on this side. Now I'm talking to you. So as told before, that is connected to the inferiorly moving muscles. So you connect the vestibular nucleus, cross to the opposite side, ascend MLF, and connected to the inferiorly moving ocular muscles are the one which move the eye downward are the inferior rectus and the superior oblique. Both are depressors of the opposite. The one which fall connected to the opposite side. The superior oblique, as you know, it recrosses and supply the superior oblique on the same side as the canal stimulation. Inferior rectus is supplying on the same side. It does not cross, it supplies the same side, the same eye. So what will happen if you stimulate the posterior canal now? The superior obliques now contracts. So what will the eye will move downward, eye in dots. Correct? What will happen to the inferior canal rectus is stimulated? Again, eye goes down, eye extorts. So both what will happen, the movement of the rotation is on one side, towards the left side, and movement of the eye is downward. Okay. Remember, this is the pathological component. This is not what you observe. The corrective component is different. Unfortunately, nystagmus is named according to the corrective component, not because according to the pathological component. So when posterior canal is stimulated, there is a tonic downward movement of both eyes, and both eyes will rotate slowly to the opposite side. What will be the corrective component now? Just the opposite side. The eye will move upward and move towards the same side. So what will happen if I'm looking from the patient's view? If right canal is stimulated, you will get an upward nystagmus and rotary component in the anti-clockwise direction. That is, the patient's you are looking from always rotary is named according to from the doctor's view, not from the patient's view. So what will happen means right will be rotating anti-clockwise. So when the patient is lying on that side, rotation is to that side. That is why it's called geotropic. So this is the pathophysiology of classical posterior canal BPPV. You get the upward and rotating nystagmus. Now, in the posterior, same thing also occurring in cupulolithiasis again, same because here again, because the cupula is weighted, it moves upward. The cupula is moving away from the ampulla. So that gets stimulated. So you also get the same type of nystagmus, whether it is canal lithiasis or cupulolithiasis in the case of posterior canal BPP. It's exactly the same. So looking at the nystagmus alone, you cannot differentiate whether it is a canal lithiasis of posterior canal or a cupulolithiasis of posterior canal. There are certain points because these are the points. I think that's not important for our discussion today. One is short lasting, cupulolithiasis remain longer time, no fatigability. So those things are there for differentiate, but for our present discussion, that is not important. Now coming to our problem now. These patients got a pure rotary nystagmus without vertically. Now let us see the connection which I told before. Once again, there is a posterior canal which is connected to the inferiorly moving muscles. Okay, that is the one we told. When the canal is stimulated, the same picture I have shown, this is the picture you are going to get. Okay, that means the tonic component to the opposite side and downward movement, and the first component, the corrective component, upward and to the same side, anti-clockwise the patient's view. Now let us see what happens if the anterior canal downside is stimulated. See, anterior canal is stimulated now. It stimulates the superior vestibular nucleus through the ventral tepal connect to the, as told before, it is getting connected to the upward moving rectal muscles. That is, upward moving muscles are superior rectus and inferior oblique. Superior rectus recrosses and supplies ultimately supplies the same side as the stimulated canal. And the inferior oblique, it does not cross, so it supplies the same side. What happens when the stimulation is occurring in the anterior canal? The stimulation of superior rectus will result in what? It elevates the eye and intones. Stimulation inferior oblique will do what? It will again elevate the eye but extorts. You can see what is happening. Both the stimulations, both the eyes are pulling it upward, but the rotary component is in the same direction, to the opposite side. That is what is happening in the stimulation of the ACC, right ACC. Okay. This is a slow component, what you observe. So the corrective component will be what? The opposite side. That is moving downward, and fast component is to the same side. Remember, the posterior canal may be same. It is moving, except that it is moving up. The rotary component is to the same side of that. Here also what is happening? The anticanal is happening. Only thing in direction is moving down, but the rotary component is the same side. So maybe it's rare, accounting for 100%. I remember that stimulation need not necessarily be in the Hall-Pix maneuver. It can be elicited by Hall-Pix test to either side, or alternatively by straight head hang position also it can be stimulated. In this position, an autocone in the anterior canal should cavitate away from the ampulla, produce exit response. Now let us see, suppose what happens if both anterior and posterior canal are stimulated simultaneously on one side. So both anterior canal and posterior canal stimulated. So naturally it's going to stimulate all the extraocular nuclei on the opposite side, upward moving as well as downward. Okay, let us see what happened now. The inferior rectus and inferior oblique supply the same side. Superior rectus and superior oblique supply recross supply the contralateral side. Ultimately come to the same side. The same side of the eye as our ear, where both canals stimulated, what let us see now. Stimulation of the ACC. When the superior rectus is stimulated, the right eye will go up and indot. Correct? Now, the superior oblique is stimulated, what will happen? Oblique's action is moving downward. It moves eye down, but again extorts. So the movement is same, the same direction. Okay? But the vertical movements are different. So when both are stimulated, what will happen? The vertical components get cancelled out. What you're going to get is rotation component to the same direction. Now let's see on the left side what happened. The left inferior rectus is stimulated. The eyes goes downward and extort. Inferior rectus is an extorter, so also inferior oblique is also extorter. The other muscle is activating left inferior oblique. It produces a upward movement, but extortion movement. So look at the right and left side. The rotary component is all on the same side, direction, to the opposite side. But the vertical components are now, if both are stimulated, what will happen? The vertical components get cancelled out. So both vertical cancelled out. What results is a pure rotary, slow deviation to the opposite side. So that is the thing which you get in both canals are stimulated. See, this is the pathological component. Pathological component. What happens? Corrective component is the same. So you may imagine our patient now. This patient is lying on the one side, the rotary component, first component to the same side as the lower eye, as you can see here on the patient, the green one. There is no vertical component. So in our patient, if upward, the superior and posterior canal, anterior canals are simultaneously stimulated, the vertical component get cancelled out, but only the rotary component is in the same direction. That summate and produce only a pure rotary nystagmus. Then you may ask why the patient is developing rotary nystagmus to the left. If you're laying left, so it should be on the right side. But here on the left side, why it is occurring like that? This is because, so it is, suppose rotary component is on the left side, what does it mean? Same, that is the left superior and inferior canals are stimulated on the left side also, correct? So it is as if the left-sided posterior anterior canals are stimulated because his rotary is lying on the left side. What happens is that when patient lies on the left side, the movement of the otoconia is the opposite direction in the affected right side canal. Here on the left side, left is not the one is stimulated. The right is inhibited because the movement is away when the patient lying on the opposite side. So when the fluid motion is away, so right side cannot get inhibited. That means in effect, the left side is stimulated. So the nystagmus again to the same direction to its left side. That is when looking at the left side also, first compound to the left side. So this is something called canal switch. When the calcium material changes from one canal to another, it is sometimes referred to as a canal switch. And more than one canal times is another condition according to some patients. This is more common in traumatic people. So what is happening in our patient? So the positive pathophysiological stimulation of both posterior and anterior on one side, probably a canal switch. See, this is my own explanation, which is a logical explanation, which I thought about it, because it's not clearly written in any textbook. This can be a aortic nystagmus. So that is about this case. So any questions? Like, could you understand with the pathophysiology of
Sir, can you explain the last part, sir?
which one the last part?
The
You mean
switch, sir.
okay. Now, in our patient, what did you observe? I'll show the video. Just 1 second for completion's sake. You remember the video first. That is when patient lies on one side. See, here the first component is a rotary component. The patient is now lying on the left side. Again, pure rotate to the left side. Okay. This is what you observe. Now, why should it occur if it's only right side is abnormality is there? You would understood why right side canal combined stimulation should produce a pure rotating nystagmus was come to right side. But the question is, on lying on the left side, why the nystagmus is occurring on the left side? There is no stimulation on the left posterior anterior canal. The pathology is on the right side. So what happens is that when you lie on the left side, the particle is lying on the right side. That fluid motion is opposite to the one which you observed on to the which occurred when the patient turning on the right side. You understood? When you lie on the right side, both canals stimulated. When the left side, right side canals are inhibited because the fluid motion is away. So what will happen? This inhibition of the right side is equivalent to stimulation of the left side. So you get the same rotating component nystagmus on looking to the turning to the left side. Is it clear to you? Or you can explain? I'll explain it once again. It is as if the left side canal is stimulated, no? With the rotating nystagmus the same, just like we explained on the right side. What happens is that when the patient lies on the left, the movement of the otoconia is opposite direction in the right-sided canal, not the one when you turn to the right side. That direction is now changed because patient is lying on the other side. So the right-sided canals get inhibited. The right-sided canals get inhibited, it is as if the left canal is stimulated. So you get the nystagmus with rotary compound to the contralateral side. Okay. Any questions?
Sir, so in this patient, it is a right-sided anterior and posterior canal between, sir.
Correct. Combination. In fact, if you ask me, I'm 100% sure I do not know. Because this is the only explanation I could explain why this pure rotating nystagmus is occurring that way. If you look at the literature, total confusion. Nobody has ever explained clearly. Some of them are wrong statement, they have made it. Joy is there, Joy is case. Joy is not there, no. Okay. This patient improved after 3 days. That's why it's a BPP, only not a central personal nystagmus. But always when you get a pure nystagmus vectors, consider central lesion. To rule out central lesion first.
Sir.
Yeah.
Sir, on lying to left side, what is happening, sir? Like right is
See, lying on the right side, the fluid motion is towards in favor of stimulating the posterior antisemitic canal, So laying the left side, the fluid motion is opposite to what you observed on the right side. When the fluid is moving away from that thing, opposite direction mean that anterior and posterior canals are inhibited on the right side. Okay. When that side canal is inhibited, it's equivalent to stimulation of the left canal. So you get a rotary nystagmus towards the left side. Okay, shall I go to the next case?
Yes.
Yeah. This is also a long case. One more case only, this case only. His complaint started 3 weeks back as paresthesia in the perianal area. Over the next 1 week, the paresthesia affected the back of the left thigh, posterior aspect of the whole of the left lower. 1 week later, similar paresthesia affected the back of the right thigh and right leg on the right side. Again, 1 week later, patient noted paresthesia around the lower abdomen, mainly on the left side. For the last 1 week, he noted paresthesia around the middle part of the left forearm and left little finger. And 1 episode of precipitated infection or leading question. So this is the story of the patient, no other complaint. So from the first instance, you may think there's an easy case of conus or annihilation, no? So this is evolution. Paresthesia in the perianal area 3 weeks back. Then 1 week later, noted paresthesia spreading down the back of the thigh and posterior aspect of the cord of the left lower limb. Then again 1 week later, paresthesia in the abdomen, mainly on the left side, but bilaterally. Then paresthesia on the medial part of the left forearm, little finger. Now this is the video of the patient. No Horner syndrome. Yes, ocular movements were normal. Looking at the palate, if one gets right palate weakness, plus deviating towards the left side. There is also wasting on the right side of the tongue, which no complaint or painless. Wasting on the tongue is deviated to the right side.
Going towards the right side.
Then come to the motor system. Tone power all normal in the upper lip. No finger nose incoordination. Lower limb tone normal. Power is normal. Everything, no incoordination, the lower limb, Nielsen test was negative. It are normally elicited in the upper limb. You can say sluggishly, we can say sluggish, but no, all can be elicited normally. Abdominal reflexes were intact. Lower limb reflexes are also normally elicited. So also angle checked. Plantar was indefinite. The sensation is all normal throughout. But pain sensation is a decrease of the medial part of the hand. Is pointing it out that area is decreased. And you will tell where it is become that up to that area is the one affected.
Normal.
The right side is normal. The abdomen also is steady decrease in the abdomen. He will tell you when it is more. That becomes normal now. It's normal. He said decrease in the abdomen. On the anterior thigh it is more, decrease in the anti-abdominal wall. A decrease in the anti-abdominal. Then the feet is decreased distal part. There it becomes normal. Decrease on the sole. In the back of the thigh also decreased. In the back of the glute region also is decreased.
ഇവിടെയൊക്കെ കുറവാണ് ശ്രദ്ധിച്ചിരിക്കണേ ഇപ്പൊ എന്തെങ്കിലും തോന്നുന്നുണ്ട് വൈബ്രേഷൻ
Vibration upper limbs normal.
ഉണ്ട് ഇപ്പോഴാ ഉണ്ട് ഉണ്ട് ഉണ്ട്
Vibration normal throughout.
ഇപ്പോഴേ മുകളിലോട്ട്
Joints is normal in the upper limb, even in the little finger on the right side, left side,
ഇപ്പോഴേ താഴോട്ട് ഇപ്പോഴേ മുകളിലോട്ട് ഇപ്പോഴാ
but made mistakes in the feet.
ഇപ്പോഴേ താഴോട്ട് ഇറ്റ്സ് എ പേര് ഇപ്പോഴാ ഇപ്പോഴേ താഴോട്ട്
He made mistake on the toes only. Rhombox is negative, he walks normally. He could walk tandem. He could walk on heel. He could walk on toes. So cranial right parietal palsy, that's very mild. Right elemental tongue weakness. Rest of the cranial is normal. Motor, upper limbs, normal tone and power. Lower limb, tone normal, power normal. Detail upper limbs normal, lower limb normal. Advanced plus present. Plantar indefinite bilaterally. Sensation touch normal in upper and lower limb. Pain and temperature. Decrease in the medial part of the forearm over the left little finger and medial part of the palm. Rest of the areas are normal. Not entire medial forearm, lower part of the middle. Trunk impaired from D6 to D12 bilaterally, more impaired on the left side. Lower limb impaired are both lower limbs below mid-shin, as well as the back of the thigh and the perineum area. Vibration normal in the upper and lower limb. JPS, upper limbs normal, lower limb impaired over both toes. Rhombox negative. So this is the area of pain loss, middle part of the hand, the palm on the left side, anterior-abdominal wall, more on the left side, and both distal part of the feet, the back posteriorly, in the perineum area and back of the thigh. This area pain loss. JPS loss is confined to the tip of both toes. All other areas it is normal. So cerebellus and then no cerebral nystagmus, no finger, no lower limb coordination. Rhombus negative. Gait, Corey, mild imbalance while walking. So this is the problem.
It is primarily a sensory system disease with some patchy involvement not following the typical length-dependent pattern, with some
Correct.
small fiber and some large fiber involvement, also in the trunk. And there is some suggestion of a lower cranial nerve problem asymmetric to one side. So, sir, although it begins like a conus medullaris cauda equina-like syndrome, but we find upper limbs and the bulbar muscles also involved. So, something like radiculoneuropathy in a PISP fashion of a disease with patchy involvement, with some suggestion of lower cranial neuropathy. I would keep, sir, polyradiculopathy or as the first possibility, a sensory predominant CIDP before a myelopathy. Sir.
Okay, that's a very good thing. Only odd point in that is that sensory part is very well explained by that. Only thing is that lower cranial involvement on one side, or right
Yes, sir,
and
that is all, sir.
that is slightly the disturbing finding in this patient. Pardon? Anyone else want to make, please?
Sir, any trigeminal sensory in this patient?
No, it's a terminal sensory loss, no corneal plus normal.
This
And
truncal associated
Yeah.
sensory loss indicates the spinal cord.
Yeah. Okay, that the problem is that, see, it's decreased the anti-abdominal wall. In fact, I did not check the posterior part of the trunk. But spared up to the knee, it is spared. To the upper part of the shin, upper part of the leg, whole thigh, it is normal. Similarly, above the trunk, it is normal, except the whole upper limb normal, except the middle part of the forearm and the little finger. But sensory loss is mainly more or always the trunk also, it is more on the left side. JP sensation is lost bilaterally in the toes. Tough case, no?
Brainstem could also be considered, sir, lower brainstem.
Yeah, correct.
Uh,
No, but only
Very
odd
odd.
point
The
is,
sensory pattern is very odd, sir.
yeah, sensory pattern or moreover, it is affecting the lowerly corners region sensory loss involvement. If you have to implicate medulla, both lateral part of spinal thalamic has to be implicated. Okay, so any other thoughts from anyone? Okay, now let us discuss this case. Just like previous one, I thought I will discuss. So he's got what is definite right tenth and rotator palsy, an impaired pain in a patchy distribution, medial forearm or the upper and lower abdomen, and perineal area extending the back of the thigh, legs up to the lower one-third of the legs, more extensive on the left side. And impaired JPS over the toes. So let us see the first, let's take the tail nerve paralysis. The site of lesion can be in the brainstem or outside the brainstem in the cranial nerves on the right side. Something like a mononucleus multiplex or a polyradical neuropathy like that is possible, or a brainstem insurance is possible. Now coming to the site of pain loss, that's the most trickiest thing in our patient. The first thing to decide is whether it is the CNS or the PNS. There's again a problem. In the CNS, it can be spinothalamic tract or multiple segmental affection of the cord. Like it crossing fiber can be affected in multiple areas. If the lesion patchily affected the multiple part of the cord also can produce. Or tract possible, but very unlikely for a tract because how can tract involvement some area in skipped areas in between and down. Now, if it is the peripheral nervous system, it could be affecting multiple peripheral nerves, roots, or sensory ganglia. All are possible. Now, let's come to the site of JP sensory loss. Again, the question comes whether it's a part of peripheral neuropathy or a posterior column affection. In the CNS, I told before, it can be the spinothalamic tract segmental. Less likely to be in the spinothalamic tract, this point I already told you, because of such patchy effects is not possible with the affection of spinothalamic tract at one place. One balance again, it's affecting only one part of the spinothalamic tract. The other also one part of the spinal. That is very odd for a tract lesion occurring in the brainstem. So multiple segmental effects is quite possible, which can explain the sensory finding. Say one in the left C8 segment region, internally crossing the pain fibers. Another in the D2D segment, central lesion in the dorsal cord. Another in the corners region, which can explain the sensory loss in the perineal area as well as in that. I think that the second possibility seems more plausible than a spinal tract involved. Now, let us see that is regarding the CNS involvement produce sensory loss. If it is a PNS is the culprit, whether it is multiple peripheral nerves, root ganglion, a mononuclear multiplex is very, very unlikely because of the type of sensory, like a saddle anesthesia in the perineal area. Very, very unusual. It's not fitting with the peripheral nerve distribution. Multiple radiculopathy is definitely possible. Or as you said, the ganglion neuronopathy can affect any part of the body. That's a possibility. So that is regarding the pain loss. Now, the site of JP sensory loss. The next question again, was it peripheral nervous system or posterior column? Then less likely to the peripheral nerves because, or a radiculopathy because it's got an intact angle check. So most likely with the impaired posterior column that would feed, the angle checks are preserved. So that makes posterior column more likely than a peripheral problem like a peripheral neuropathy angle check. The other areas where no clue, because when with the areas of pain loss, those reflexes are all intact. So we cannot say it is the cord or the periphery. But here we can be relatively certain that the loss of posterior column is most likely to be a problem in the posterior column than in the PNS, peripheral nervous system. Now, the next question, can the lesion everything be explained by medullary lesion by stretch of imagination? So what are the points favoring? Yeah, anyone want to make a comment? No. So multiple
Explaining
cranial,
nerves.
multiple cranial nerves in a single site with bilateral tract affection. Yes, good possibility. Which can explain the pain loss in the left lower limb, which started first. He's telling first started the left lower limb. When the cross tract is happening in the left side. We can also explain the posterior column sensory loss by implicating the gracile nuclei bilaterally or its crossing internal arcuate fibers. See, this is well known because in medullary lesion, sometimes the sensory loss can be confined only to the upper limb. Sometimes due to posterior column, we're talking the posterior column, or only confined to the lower limb alone. But that is because on the decussation of the internal arcuate fibers are different two planes that I will show the picture. The lateral lesion is more likely since small lesion can explain bilateral sensory findings in this patient. So there are points favoring medulla in this patient. You can explain the posterior column, you can explain the left side is spinothalamic tract. What we can't explain the right side is pain loss, and the canal can be explained. So this is what I'm trying to say, that this is the gracile and cuneate nuclei. You can see the crossing, the internal arcuate cross to form the medial lemniscus. So imagine a lesion confined to the sensory decussation as you can shown here. What you are going to get total loss of posterior column in the upper and lower limb. Suppose it is confining only those crossing fibers from the cuneate fiber nucleus, anteriorly situated there. Then you get sensory loss only confined to the upper limbs, so-called pseudo-syringomyelic pattern. But if it is confined to the posterior dorsal part, then it can only confine to the lower limb alone because of the crossing of the gracile fibers are affected. The class No, so what are the these are so these things you can be explained by a medullary lesion. But what are the points against? Bilateral spinothalamic affection with unilateral medullary lesion is very odd. Even with lesion extending to the central medulla, very difficult to explain. Because you may have to consider a lesion extending almost the entire medulla since spinothalamic tract are situated far laterally. See, look at the orientation of the spinothalamic tract situated. That's a location. If both tract has to be implicated, the lesion has to be extensive crossing on one side to the other. So that's the point against the medulla in this patient. Moreover, the painless pattern is not like the tract pattern with the skipped areas in between. Again, that's another problem. So that makes it difficult to solve a spinothalamic medullary localization. Even if you want to explain, you have to implicate the outermost part of the spinothalamic tract bilaterally to start with. Because that is the area first they had, perianal sensory bilaterally. So those things makes little odd. So taking this into consideration, what will be localization? The other possibility is a multiple segmental affection of the spinal cord. One in the cervical cord, another in the mid-dorsal cord, another in the cornus region. Okay. And of course, the medullary lesion can explain the posterior column as well as. So what do you think about these possibilities, likely or not? You agree with my discussion?
So many levels of cord lesions, but we are not getting women signs that much. So
Your point is well, right. Very well taken. But only thing is that with cord mean is not the entire cord is affected. You see the innermedullary lesion, that is the crossing fibers are affected. But just like a syringomyelia, no, you get the pain fibers cross to the opposite side, and the central part will produce only segmental like or jacket like sensory loss. I'm only postulating that possibility. The tract lesion producing skip lesion is very odd.
Yes, sir.
The various possibilities I'm thinking. Yes.
Yes, this can explain multiple segment infection.
Segment that can explain chain involvement. Okay,
the
now let's
abdominal
go.
reflex was normal in this patient. So if you are considering a mid dorsal, we might get some asymmetry in the abdominal reflex if there is a mid dorsal level to the
No,
coordination.
right. The problem is we are not talking about what your point is correct. But the point is only the pain fibers are lost. The crossing fiber alone may be affected. You can have the same thing. So what happens? The reflex carrying fibers are different. The abdominal is different. They go from afferently polysynaptic coming back to the motor nerves. But that pathway is different from the crossing spinothalamic fiber. That goes in the middle.
Yes.
That area alone is it's all theoretical possibilities I'm talking about. Okay, what are the bedside tests? This is one possibility I kept, but I disproved it later on by one test. If he had been a cornus lesion, endometrial cornus lesion, producing loss of pain as he postulated just now, what bedside test will you do? To exclude or include the second possibility?
But anal wink reflex,
Yes, correct. Anal reflex is
Anal and
linked.
bulbous are another reflex.
Yeah. But not the bulbar card, I did the anal reflex and sphincter tone. That was normal.
yes,
So
6 elements.
that possibility is also less likely. So where are we now?
Multiple radiculopathy.
Yeah, possible. But it is difficult to explain only painless patchy like that.
And so
Okay.
ganglioneuropathy can also be a cause because in some patients we have seen that patients with Sjogren syndrome, they might also show lower cranial nerve involvement along with multiple
Yeah.
patches.
Yeah, right. So ganglion neuropathy can affect the small fibers correctly, but by and large, I mean, invariably they have got large. That's a mainly affected is the large ganglion cells.
Yes.
The posterior
Yes.
corner fibers are
They
huge.
should have
And
some
have been-
ataxia, but gross amount of ataxia they generally have.
Yeah, right.
Ataxia
Here
is
is
absent in this.
ataxia is absent, reflex loss is not there. There is no reflex loss except the nothing, no reflex. This load again is that's a ganglion neuropathy.
Sir, what about the preganglionic segment, the CISP type of the ganglion?
Again, same thing. Clinical presentation is same. They present with sensory ataxia, areflexia. The reflex are all well retained.
Painful paresthesias are more common in CISP than in ganglioneuropathy because negative symptoms predominate in ganglionopathy, whereas we get some positive symptoms in CISP.
Yeah. And that can possible in both. Both can produce that thing. That may not necessarily differentiate, but as you said, it may be more in CASP. Okay, now what investigation want? So the only possibility now remains is bilateral discrete lesion. One in the medulla, which can explain the right 10th and 12th cranial nerve and posterior columns loss. That can be explained in the medulla. And pain loss on the left side also can be explained by the medulla. But what is the lesion responsible for the pain loss on the right side? On the right side of the abdomen and the right side of the posterior aspect of the thigh and this thing. We have to implicate multiple lesions in the cord or a patchy affection of the spinothalamic tract. So this is the only thing which we can do. So we have no clue to point out which part of the cord is affected. It can be anywhere above the left cord above C. That's all what we can say. Okay. So what do you want to do?
NCS followed by neuroimaging.
Okay. So MRI was done. MRI where? That's the question. You want to do the brain, you want to do the cervical cord, you want to do the dorsal cord, you want to do
Brainstem with screening of spine, sir. Brainstem with screening of cervicodorsal.
Right. Okay. So MRI brain, I'll show the MRI brain now. That is the lowermost, uppermost part of the cervical cord, and that is the lowermost of the medulla. Can you make out a hypernus lesion the left side of the medulla? I'll show the picture later on.
Yes.
Clear
Yes,
picture. That is a T2. This is the T2 coronal. You can see that is the uppermost part of the cervical medullary junction. Another on the left medulla. There again, I'll show it later on in a clear picture I'll show. This is SAG MRI. You can see the lesion on the upper cervical, lower medulla region, the region of that clavicle region. This is the flare. See the hyperintensive lateral medulla, left lateral medulla. Then another in the cervical cord. Two discrete lesions. SWE was non-contributory. It's a diffusion. No diffusion restriction. Then you can say T2 with thin window, the window adjust, we can quickly make out the lesion there. Almost a part of the spinal cord. Another lesion, the left lateral medulla here. Again, showing the corresponding area of interest. Flare and T2. It is near the gracile nucleus. That's a corresponding cut in the. You can look at the sagittal cut that shows the level of the lesion. So just uppermost about the cervical, the hyperness you can make out there. The other one is that area, the lateral medulla. That is the area of the lateral medulla lesion. You can make out the coronal cut also there. Different from that of the cord lesion.
That's a lesion, coronal line.
That is the coronal cord lesion there, corresponding one. The hand arrow is pointing to the lateral medulla lesion. So one here, one in the lateral medulla. The spinal cord lesion is central, posteriorly situated, implicated in the gracile nucleus, and the other is lateral medulla on the left side. We got a finding on the right side, field of involvement. This is again CC, I think you skip that thing. And contrast is also done. You get a patchy contrast enhancement of that particular cervical cord lesion. No enhancement of the medullary lesion. Upper part normal. I'll show the area of interest also once again in depth. That is a enhancement, dot-like enhancement of the bone of the lesion, the cervical cord. That one. No enhancement of the lateral medulla lesion. Lateral medulla lesion showed no enhancement. Hypodense. So what else you need now? Certain things you can explain here. You can explain the posterior column loss in the lower limb can be explained. Pain loss difficult to explain with this lesion. Lateral medulla lesion can explain the pain loss on the right side, but not on the left side.
Sir, cervical and dorsal points.
Right. So MRI the cornus region, MRI the rest of the cord. This is a cervical lesion. No cord lesion seen. There's a dorsal cord. Again, the lumbar region also normal. Then the cervical axial. bringing down. Normal. Going down up to the corners, we took an axial cut. No lesion seen in the cord. Then it took again thin cut in that over cornus epicornus region. No lesion. That is the lowermost part of the cord. Nothing in the lumbar spine also is normal. Now, what are the investigations you need now? Only two
Yes, sir.
lesions. Some lesions are there which we can explain, but the lesion must be there.
So the lesions look like demyelinating lesions. Considering the age, we should consider secondary demyelination before primary demyelination. If we have to consider primary demyelination, we can consider the early part of PPMS. However, we should do a CSF testing with detailed vasculitic workup along with CSF, OCP, and IgG index to see whether what is causing the demyelinating etiologies.
Okay, you're perfectly right. So it can be secondary or lymphoma, less likely because there is no enhancement, there only peripheral patchy enhancement. And we also thought that way. So CSF showed 45 milligram protein, no cells. OCB was sent, result has not come yet. We did MOG and NMO antibody because we seeing the medullary, cervical medullary region, that's the area for NMO, that came as negative. ACE level was negative. Then CSF otherwise normal protein, except for the OCB has not come so far. I did a paraneoplastic workup and CT chest abdomen negative. We could do for some of the secondaries from somewhere else. Then ANA profile was also negative. So I put the patient on AV and asked for follow-up.
So the patient's NCS was done, sir? NCS?
NCS was not done. Because initially we could have done that if the MRI was normal. Once you find the MRI, we know the lesion is there.
So such a degree of albuminocytological dissociation with some peripheral findings.
No, there is no albuminocyte dissociation. Protein is normal.
449, sir, protein.
No. That's a wrong report. No, it is in our lab. It is 449 milligram per liter.
Okay, sir.
That's the problem. You cut off the last one. It's only 40 milligram deciliter. The report is the report in milliliters. That's the problem. Okay, in fact, this case is about not for the diagnosis, what the etiology is, to difficult localization. That is why the interest in this patient. I never thought that lesion alone can explain this particular finding, but this is how you presented.
So what explains the motor weakness of the palate and the tongue on the right side, sir? Because there is the lesion there, sir.
We did not find a lesion that in the MRI to account for that 10th and 12th on the right side. You can explain by that lesion on the spinal cord because there is a lowermost part growing onto the medulla. 10th difficult to explain.
The tongue is doing some atrophy, sir. So it may be an old lesion which has gone now.
Exactly.
Maybe. But still you have to explain that old lesion.
There may be another lesion.
Sir, did the patient improve with steroid?
No. The thing is that this case is only saw it last week only. I sent him on steroid, asked him to take injection, come back after 2 weeks. I'll give the follow-up later. What happens. It's only difficult to find what is it. It's only follow-up will tell you what it is. But then the presentation was the one which is quite atypical of mass lesion like that.
Very atypical.
From the first time when you get the history, you get a feeling that it's a straightforward corner caudal lesion. But analysis, everything was normal. Okay, shall we close today?
Thank you, sir.
Okay. Okay. Then.
Thank you, sir. Thank you, sir. Good night.
Thank you, sir. Good night.
Night.
Good night.
Good night. Night.